Hi everybody, I'd just like to welcome you today to our very first Epilepsy Smart Australia webinar with our first guest, Professor Patrick Kwan. Patrick is a professor in the Department of Neuroscience, Central Clinical School, Monash University, and is a consultant neurologist and head of the epilepsy at the Alfred Health. His research looks at understanding the effects of long-term treatment, identifying factors that affect outcomes, mechanisms of drug resistance, identifying novel molecular targets for the treatment and prevention of epilepsy, and translating research findings into the practice of personalised medicine for epilepsy. Patrick has recently published Treatment Initiation Decisions in Newly Diagnosed Epilepsy, a longitudinal cohort study on decisions around whether or not to start treatment for newly diagnosed treatments. He's also exploring the utility of AI in predicting outcomes for medication changes and decisions. So welcome, Patrick. Honor is going to be co-host with Patrick for today. This is our very first seminar, folks, so be patient with us. I'm going to hand across to Honor. She'll just sort of describe how we can engage throughout the seminar. So thank you very much.
Nice to meet everyone.
Hello, hi Patrick and everyone. And thank you for, today's webinar is going to be a really interesting one, I think, and a really nice interactive one. So Patrick had suggested sending in a number of questions beforehand. So I've got a list of questions for Patrick that we can start with, but please do feel free if anything kind of comes to mind, or if anyone would like sort of to elaborate further on any of the questions, please feel free to either sort of unmute yourself and just sort of chime in, or you can type questions into the chat and we'll keep an eye on that if there's anything in particular that anyone would like to follow up on a little bit more. But Patrick, I thought I might just start because I saw, I think on the ILA Twitter page, you're giving a bit of a talk or a sort of promo of some of your research that will be presented at the Asia Oceania conference coming up. So as Lisa was saying, you're doing a lot of research into these really amazing sort of large epidemiological sort of studies looking at just first decisions and kind of just treatment pathways and the process of kind of choosing a treatment following new diagnosis of epilepsy. And I think one of your recent papers was looking at, around a third of adult patients with newly diagnosed epilepsy are not necessarily treated immediately, which might be for a number of reasons. So would you like to just sort of maybe talk a little bit about some of that research to start with?
Yeah, sure. First of all, I'd like to thank Lisa and with Honor and the rest of the foundation for giving me this opportunity. And it's nice to meet everybody on Zoom, on the different screens. I love your different backgrounds. Some have bookcases, some have in the ocean. I've got a virtual background as well. I'm actually at home. So I think in this COVID world and the new normal, and this could be open us up opportunities for different ways we can interact. So I want to, when I listen and Honor kind of approached me for doing something like this, I was very excited actually, and I felt it's really good that the foundation is looking at interacting this way with clinicians, which we do, I guess, more with among the clinicians or professionals. Sometimes we do it with patients and the carers, but less so with the actual people like yourself who are supporting the patients and carers. So I think it's really innovative, and I want to highlight how much I appreciate. And then when we thought about what is what should the format is, because recently I've found the podcast seems to be taking up their podcast format more kind of like a interactive chat. I mean, I think we've all been to a lot of conferences and lectures, listening to not people with gray hair standing on a platform, giving you a didactic lecture. And I'm not sure about you, but for me, it's not the best way to communicate. So I propose let's have more like a Q&A, or like a journalistic style, if you like. And I hope this will work out. We'll see how it works out. So with all that, I think I'm happy to for you to chime in with questions. I know there's a big brother or sister behind controlling all the sound, so you may be on mute, but if you want to type questions, or I'm sure you can put your hand up and ask questions. So with all of that, yep, coming back to Honor's first question, yeah, it is something that we've been thinking along for quite a while, and I've been in this business, so to speak, for more than 20 years, trying to understand the outcomes of epilepsy treatment, how actually patients respond. And a lot of research, as you may have come across, are looking at, we get almost like a repetitive chant, like 30% not seizure free, 30% patient not seizure free. That's all very well when you look at patients who start treatment, but often what we forget is before the treatment stage, what happens to the patients. And even going further back, what happens to the patients before they have diagnosis. And the more thinking we are now putting into it as a research theme is that I think we need to understand the whole journey of the patients, even before they become patients, because we often have naively we believe that, or we assume that patients don't have a life before their epilepsy. It's kind of, they only have a life since they've got epilepsy, and that's why we're interested in them. But in fact, we forget patients, they do have a life before they have epilepsy. They have a life before they have their first seizure. So what actually led to them having their first seizure? What happened? What led to them having their second seizure, so that they're diagnosed with epilepsy? And even at that point, usually it's only at that point that the specialist centers like us start having contact with patients. They come to our first seizure clinic, which again, even that is a very, is not universal. Many places, centers in the world, if you in the US or Europe, patients the centers can only have the capacity to see those refractory patients, right at the very end. So here in Australia, we're lucky. We have first seizure clinics at least in major metropolitan centers. But what we realize is lots of patients, actually, there's a bit of a gap. They might present to their GP, to ED, but they don't turn up to clinic. Even if they turn up to the first seizure clinic and the diagnosis is made, not all of them will start treatment. So if you only look at patients' outcomes of those who start treatment, you're missing a whole piece. It's a tip of iceberg. You're missing what is underneath the water. So that's, I guess, what we're trying to do here is to, how can we map the whole journey? So one of the first steps, I think Honor just mentioned, is looking at patients who are diagnosed but not commenced on treatment. So that at least taking us one step back from the point of starting treatment to the point of being diagnosed. But we're also, at the same time, we're looking at further back, we're looking at what happens to those patients who have their first seizures and whether they come to the first seizure clinic or not. And even further back, before they come to the first seizure clinic, what is their health status like? And we're doing something along that line by looking at linkage data, linking to admission, diagnosis, the statewide hospitalization and attendance data sets to try to understand what happens. So we can map out, because I'm a strong believer, if you don't know the past, you don't know how to map the future. So knowing what happened in the past is crucial. There's a long answer to your question.
No, it's yeah, that's fantastic. Is there any sort of instances? So yeah, when you're sort of talking about looking at that and looking at even before the person's had their first seizure or before they've even started on medication, I think one of your papers was looking at that group who aren't started on medication, and it sounded like sort of some were. It was a patient decision, so they were not convinced in the diagnosis perhaps, or not convinced that a medication was for them. Sometimes it might have been maybe a sort of, they'd only had one seizure, so the diagnosis of epilepsy wasn't made yet. From your perspective, in terms of kind of treatment decisions and treatment pathways. What are sort of some of the cases where you wouldn't suggest medication at that first sort of seizure or first meeting with the patient?
Yeah, I'm just pulling out the paper as we speak, because I don't have all the numbers in my head, but you're right, it's a combination. And so we have and these are data from some first seizure clinics based in Western Australia in Perth. We collaborate with Nick Lawn, who I'm sure you've heard of. He's kept one of the rare, very well curated and collected and carefully followed up data sets in the country or even in the world of first seizure patients. So we're able to track their history quite well, very well, have high level of confidence of the diagnosis. So even in his data set, about 30% of patients, they were not treated immediately on diagnosis. They were then followed up on another I think 3 to 5 years, most of follow-up duration, about 3 years. And even at the end of follow-up, about 10% were not treated. So obviously 20% more were treated during follow-up. And most of the time it's because the patients had more seizures. And the reason not started treatment immediately, when we delve into it further, it seems there are two groups. So there's one group where the clinicians just didn't recommend, the neurologists didn't recommend. And you might be a bit surprised, we can come back to it. And there's another group where even when it was recommended, the patients declined treatment, didn't want to start. And when we look at the factors, risk factors, so it seems that it's those who are younger patients who are less likely to be treated immediately, as you might expect. Patients with only had one seizure were less likely to be treated. But these patients also have risk factors for more seizures. So they actually fulfill the new definition of epilepsy. You know, they have a brain lesion, or they have had risk factors, they have abnormal EEG or MRI. So they are, by definition, they have epilepsy, but because they've only one seizure. So we can come back to how we interpret the results. And then quite interestingly, is those in the higher socioeconomic class were less likely to start treatment. You would have thought the other way around. In developing countries, you would have thought it's people who can't afford treatment, but in a wealthy country like Australia we're living in, is the opposite. And we think that probably because the highest socioeconomic class people they can afford not to start treatment. You know, they can afford, quote unquote, to have another seizure. Their office job, they don't need to drive, they're not working, they live in major cities, they can catch an Uber, they can afford to. Whereas for maybe a lower socioeconomic class, more manual work, people, they can't afford to have another seizure because the impact would be just so big. Possible. We're not sure. We need to look into it a bit more. As far as having just one seizure and not starting treatment, it probably reflects that people are still, when they look at the investigation results, they still look at it take it as a pinch of salt. You know, in particular, the imaging has a bigger effect than the EEG. So they can see a lesion in the brain, they can see a brain tumor or carcinoma or something, to start treatment, then squiggly lines on the EEG, which doesn't mean anything to the patients. So I think it tells us there's some sort of communication we can do, better communication with the patients.
Yeah. And thanks, Kel. So Kelly's just popped a question in to ask, do you know if there were sort of cultural aspects? So in the study, we're looking at differences in sort of different cultural communities and their perception of epilepsy and how that might impact uptake of medication or acceptance of the diagnosis.
Yeah, that's a great question. I think we did try to look at whether First Nation patients were less likely to start treatment or not. From my recollection, that wasn't a clear factor. It was interesting. We did we asked a similar question using a New Zealand data set. I'm not sure whether you've come across that paper on it. That was published in Epilepsy the year before, when we collaborated with people in primary care in New Zealand, and then access the New Zealand diagnostic and prescription database to look at patients with, again, new onset epilepsy, what is the untreated percentage and the outcomes. And that study design is a bit different in the sense it's not relying, we don't have the same kind of clinical diagnostic certainty that you get from a clinic-based database. That's very much a diagnostic coding study. But nonetheless, what we found in that study was indeed the Maori population were less likely to be treated than the non-Maori population. The difference was very small. Statistically, there was difference, but you can argue clinically it might not make much a difference. But that's an interesting angle to ask. I think ultimately is the sample size. We're not sampling the right population. So to answer that question, I think we need to extend the study to like northern, where just states where they have a higher prevalence or population percentage of First Nation people.
Interesting. I might sort of move on to some of these questions that we got sent through beforehand, but was there anything else? Did anyone else have any other sort of questions around this sort of start of the treatment journey and these sort of early considerations on first diagnosis and first seizure?
I think if you have clients, who do want to discuss, and my personal experience is that it is exactly this population, the newly diagnosed population, I think has the greatest need for support like from Epilepsy Foundation, because it's a major thing, it's huge, for someone to be given the diagnosis. Not to say the patients are already refractory, they had a 10-year history. Not to say that the work of the foundation is not important, of course, very important, but those are seasoned patients, and they've been around, they know what, they kind of expect what to get. I think for someone just newly diagnosed, I often think if I were the patient, I'll be completely shocked. And I don't know how I would take it, because it changes your life, that labeling, and you start having in your mind all sorts of questions. How is it going to affect my work? Driving always a big problem. What's my life going to be? Am I going to have a family? I'm sure there are millions of questions. And sometimes I wonder in a consultation, a medical consultation, when we discuss starting treatment, whether how much of that actually gets into the patient. Because I bet all they're thinking is, how am I going to tell my family? Am I going to tell my boss what am I going to do, rather than whether I'm going to get a skin rash from Tegretol or something. So partly I think is and I often say to them, there's a great support or portal or a place you can get a lot more information like the Epilepsy Foundation, and I often recommend the patient getting in touch. And I think that's where maybe the foundation can provide that kind of education about treatment. And because the reality is, for those 30% of patients who didn't start treatment right away, many of them have another seizure, like more than 60% within the follow-up period have another seizure, and they ended up starting treatment. And what we're looking now is we're looking at what are the consequences. And what we found, a lot of them, like a quarter of them, would have seizure-related injuries. We had a patient who had a car accident in the untreated period, who ended up ICU, major health problems. So how to get the message across that if the treatment is recommended, then there is it is very important that they realize the consequences of more seizures.
And that, I think, sort of ties in nicely, because Kel's just asked another question of, is there something we can do in the community to increase compliance and understanding after that first seizure clinic sort of admission, or after that first seizure clinic meeting? Maybe checking in with a referral to Epilepsy Foundation, or is there something the foundation could be doing to connect with that group?
Absolutely, absolutely. And I can envisage another study in my head, which is look at patients, look at those who, of those 30%, or the newly diagnosed patients, those that get connected with the foundation and those that don't, and look at their, the rate of starting treatment and their outcomes. I mean, that'd be a great study to do, to demonstrate how much you can impact on patient outcomes by having support in the community through the organizations like the foundation.
Yeah, fantastic. Eileen, I think I noticed you had your microphone off before. Did you have a question? Sorry to put you on the spot.
That's all right. No, I was just typing in the chat, so I'll just ask it. I was just wondering if you could speak a little bit more about the new definition of epilepsy.
Right. So the traditional definition for decades is you need to have 2 seizures 24 hours apart to be diagnosed, and assuming these are so-called unprovoked seizures. So they're not due to, for example, someone having an acute stroke or acute head injury, or they are hypoglycemic, they have low sugar. So these are acute causes. So excluding all these, they need to be unprovoked. And if you have 2 more than 24 hours apart, and the reason for the 24 hours is because there is good epidemiology study to show that the risk of further seizures, if you have multiple seizures in one day, your risk is no different from someone who only has had 1 seizure within that day. So that's, and the concept, I think, is maybe something happened on that day, got on wrong side of the bed, something happened. So it could have been just a one-off. So that's the old definition.
Yes.
And again, it's based on epidemiology study to show once you've had more than 1 seizures, then the risk of further seizures is much higher. So epilepsy, the concept of epilepsy has always been whether someone has something intrinsically wrong in their brain such that they are prone to more seizures. So it's a tendency to have more seizures. And it's hard to say whether someone's a tendency to have something if it's only happened once. So that's the kind of concept that we've worked along. And it's still the basis for the new definition to understand that rationale behind. And the studies done many studies have shown if you have 1 seizure, the risk of another seizure in the next 2 years is about 40%. That's the figure I usually carry in my head. So when I counsel patients, once unprovoked seizure, next one in 2 years, 20%, for about 40% in average. And I would say high and low risk within that 40%, that's an average. But once you've had 2 or more seizures, then the risk goes up to 80 or 90% for more seizures. And that's why, that's when the tip of the balance of the scale tips, the tips over to the treatments. And the other is, the definition is meant to be operational. It's a practical definition. The really pragmatic questions, do you start treatment or not? So we say, if the risk is only 40%, then if you start everyone on treatment, then 60% will be treated unnecessarily. So you wait for the second one. If the risk is 80, 90%, then it's worth starting treatment. That's the rationale. Now the new definition, what it does is to address the question scenario where a patient has only had 1 seizure. So, but then in one patient, 1 seizure, if they have risk factors to have more seizures, then the argument is they should be treated as someone who has had 2 seizures. So the way the IOE has done it, approach is to look at what are the risk factors that are measurable. So these are, you have abnormal imaging, say someone who had a stroke in the past, there's a clear infarct in the brain, a lesion in the brain, or abnormal EEG, because we know people with these 2 risk factors, their risk is almost double compared to someone who doesn't have these risk factors. So if you read the paper, it would say if the risk goes up to 60% in the next 10 years, then it will be equivalent to someone who has had 2 seizures, and the patient would fulfill the diagnostic criteria of having epilepsy. I think that's very, that's conservative. 60% in 10 years is a long time. What we found in our study, even with a 3 to 5 year follow-up, is that 60% will have another seizure. So the actual risk is much higher than 60% in 10 years. It's more like 60% in 3 or 5 years if you have these risk factors.
Yes. Thank you very much.
Thanks. We might move down, sort of down the treatment pathway a little bit. So someone started medication, but a few of the questions that we had come in were sort of considerations around how to guide someone best if they've missed a medication. So if someone calls sort of worrying about missing a dose, and then should they take 2 doses close together or should they leave it, sort of questions around that. So if someone's missed their medication, what would you usually recommend or suggest?
A good practical question. So I usually recommend the patient make it up as soon as they can, and then try to push back the second dose a bit later on. So it's easy to implement when it's like a BD twice daily drug, and if they forget the morning dose, they remember by lunchtime, you just take it and then you push back the evening dose a bit later on. I think it's a more problematic when it's a once daily drug like perampanel or something. Then I think it depends on what dose they're taking. Some drug like perampanel, if they're taking 4 milligrams, they suddenly take 8 milligrams, they'll probably get a lot of side effects. But if it's like lamotrigine, 50 milligrams, taking 100 milligrams, the therapeutic the window is quite wide, so they're not going to get toxic. And that's true for most of the drugs we have. Actually, if they're on a low dose, doubling the dose is not going to cause immediate toxicity. So I would look at what drugs they're taking, but the general principle is you take it as soon as you remember. And if you can't do that, then look at the actual drug and the dose, see whether we can just double it up and make it up. The other common question is, patients ask me, what if I was sick, I threw out my tablets, and what do I do? I'll just say, just take it again, right? Because again, the therapeutic window is quite wide, and the drug safety is pretty wide for the drugs we use, and it's very hard to overdose just by doubling the dose, on these on the anti-epileptic drugs. Does that make sense?
Can I just ask, Patrick, what happens if if the patient is on a number of anti-epilepsy medications at the one time? So it's not just one dose, but they're taking in numerous. And then is the time frame still the case, or is that a different scenario altogether?
Generally speaking, is still the same. And again, but I'll look at exactly what drug and what dose. If they are taking already in the upper limit of the usual dose we give, then doubling may be really too high for them. But if it's on a small dose, it's still within the top end of the dose that we would use anyway, then I think doubling is usually safe. Yeah, so for someone like that, they probably need to have a clearer guidance from the neurologist. Say, this drug you can double, this drug you can't. If someone is taking multiple drugs, because for those patients, they are probably under neurologist, they're complex, they've got a lot of other issues as well. So I would suggest in that case, have a clear, action plan from the neurologist.
Any other questions around sort of missed medication or missed doses from anyone? Some of the, in terms of kind of emergency medication and prescribing emergency medication, there were some questions around whether or not, would you ever prescribe sort of rescue medication for someone who's not taking anti-epileptic drugs?
Not taking. Let me think. I probably have. Not many, maybe less than a handful for patients I've done that. And usually is for those patients who have very infrequent seizures. And by infrequent, less than one a year, for instance. And also some patients who believe, again, at least they can convince me there is some kind of warning. Often patients feel that I can feel it coming on. I feel there's some warning symptoms they get. Give them sufficient time to take a preventative treatment to prevent the seizures. So I think I've done that, but rare. I would say probably less than a handful of patients I've recommended that.
Yeah. Are there any other, so yes, also a clear kind of warning sign or warning symptoms might be one factor in the decision making. Are there other sort of factors relating to that? So particular syndromes. So I think Kel mentioned Beck's, or, you know, factors like remote location or sort of parental request concern that might factor into your decision making.
Beck's, I mean, I'm not a pediatric neurologist, so I don't know the exact, you know, practicality of Beck's, but I know a number of, you know, children with Beck's are not necessarily treated, because usually nighttime focal motor seizures. For I think remote location, I would argue there's even more reason they should be treated regularly if they in a remote location, because the risk, you know, their access to emergency care is more limited. So it's probably the other way around. But for me, I think having a clear, you know, warning and having doing a good carer support that someone can administer that emergency treatment is essential. So, and the patient needs to, either the patient themselves or a carer can, you know, capable of delivering that level of care. So I don't think it's not a cup of tea for everyone, I think.
And what sort of factors might be made or be part of the decision to remove the rescue medication order, or sort of, is it kind of improvement, I guess, or amelioration of their seizures in general, or do you tend to only have rescue medication orders for short periods of time?
I guess it's the same principles. You know, who's going to administer it? What's the experience been? And you do sometimes worry about overuse or misuse. Maybe I'm not sure I'm answering the question. Maybe
I might expand,
Kelly,
if that's
yeah.
all right.
Who's asking that difficult question?
Yeah. I'm just thinking about the children who've been seizure-free for a long time, like 5+ years, and every year having to have emergency medication added to their training added to for school. And when is the point that, you know, they've been so well, they may have even been off their AEDs, that we would actually stop the midazolam?
And they haven't actually needed to use the midazolam. Yeah. When
it's a safe time to actually do that? When would you have a time frame?
Yeah. So it's deciding when the patient or the child may be considered to have actually grown out of the epilepsy.
Maybe.
I don't know what the pediatricians do. I mean, in the adult world, you know, a couple of years, 2 or 3 years, then you start thinking, you know, do we still need this sort of plan? Although I have patients who have seizures only once every 5 years. And I think you have to look at it on a case-by-case basis. Part is comfort. You know, do they feel comfortable to have that kind of taken away from them? You know, they look at it as that might cause anxiety or stress. So whereas for some patients it's delabeling. They want to get rid of the label of having epilepsy.
I'm also thinking of in the disability organisations where we have older clients who've had epilepsy for many, many years. They might have had the diagnosis 40 years ago. They've routinely been on the midazolam for a number of years, and it's just been the GP signing it every year. That's, you know, when does that get reviewed?
So something get charted but never used.
Yes, that's right. Tricky.
So the request usually come from the homes or from the parents.
Usually the supervisors of the house, or even the parents too. But
we still need to chart this or not. So the client is off medication, for many years, no seizures, and still get charted.
Well, they might be on their medication, but they haven't needed rescue medication for many, many, many years.
Yeah. Then I think you can make a kind of common sense judgment.
Yeah.
For someone who's off medication, you can reassure them. Again, there's another definition where someone is no longer has epilepsy and there is no treatment for 5 years and no seizures. So that's regarded to the epilepsy has remitted, they've gone to remission. So that scenario, I think that's a good level of confidence that you don't necessarily need to chart this sort of rescue medication. If they are on medication and no seizures and nothing for 5-10 years, I guess they look at practical side, what is the implication of charting it? Does it mean that they are, if it's restricting their movements, the client's activities, if it causes any restriction, then I think can take it away. On the other hand, if it doesn't change anything, then you might as well keep on the chart just to keep everyone happy, I guess.
It's always the training aspect of it, having to have people trained and carers around that are trained to give it. That's been usually their biggest concern.
I see. I think it's I think if someone hasn't had any seizure for 5 years, because 5 years is sort of arbitrary, but there's a lot of evidence when we look at medication withdrawal, when we look at even a patient who are off treatment, the risk of more seizures. So the people who are off treatment, no seizure 5 years, their risk of having another seizure is the same as someone who has never had epilepsy. That's why the IOE now says, that you can say the epilepsy is remitted. And for patients who have been on treatment and no seizure for 5 years, there's some studies showing if they come off the medication, withdraw the medication, the risk of relapse is the same as someone who continues to take medication. So 5 years is a reasonable, it's a defensible cutoff if you want to say, look, this client actually doesn't need to have this rescue medication anymore because he's the same as the next door neighbor.
That's good. Thanks, Patrick.
Thanks for jumping in there, Kel. Some of the, unless anyone had any other questions about kind of rescue medication, we might move on to, there are a few questions as well about kind of balancing, which I know is a huge part of your role as consultant neurologist, but balancing good seizure control versus side effects and kind of taking into consideration, obviously, the patient's experience of those side effects, but as well as the potential consequences of long-term medication. So we did have a few, just to start with, maybe, about sort of guidelines around long-term treatment and bone health and what sort of best practice with regards to that. Do we need to do kind of baseline bone density testing, or what are the sort of latest recommendations?
There was there was a time when there's quite a lot of interest and a lot of research around this has been come up from studies in Melbourne, as I'm sure you know, looking at long-term side effect on bone health from anti-seizure medications. I haven't seen more recent study, so a lot of these questions are still there. Where do you do baseline screening, and then how often do you then screen? Kind of practice varies, I think, from neurologist. So I generally still look at what drugs have been on. So clearly enzyme-inducing drugs and other older drugs that are not enzyme-inducing, that include valproate. Also, they can increase the risk of osteoporosis, osteopenia. So my own practice is that when someone has been taking the medication for more than 5 years, then I would do a DEXA scan. In reality, because these are older drugs, lots of the patients when they come to see us, they've never had a bone scan done, but they've been on it for 20 years. So my first test is to do a bone scan. And then how often then you screen depends on the results. So if it shows osteoporosis, then I would refer them to endocrinologist. They need osteoporosis treatment. If it's osteopenia, then I would do a yearly scan. If it's normal, then I would normally do one, and after another maybe 2 or 3 years, and monitor in that way. And the more tricky question is, if someone has been found to have osteoporosis, do you change their epilepsy drug? That's a more tricky question. And again, it's a very personalized discussion, individualized talking to patients, because it's all weighing up pros and cons. You know, if you change drug, they're well controlled, you're rocking the boat. If you don't, then the osteoporosis, they need to take another drug, and they may get worse because all the enzyme-inducing drugs they're taking. So again, the decision comes down to weighing up the pros and cons and the risk that patients willing to take. And sometimes, I've changed it around. I've changed from. It's probably no different from pregnancy. You're changing a drug to prevent something in someone who's well controlled on the epilepsy drug. So you do it slowly, talk through the process, and keep your fingers crossed, I guess.
Yeah, so it does sound like it's very sort of on an individual basis and based on their preferences as well, taking those into account. Side effects or considerations around medication and contraception and pregnancy was also something that kind of came up, that people were interested to hear a little bit more around. So particularly, I think someone sent in a question about latest consensus on treating women of childbearing age with GGE in particular. Has there been a sort of update in the guidelines around GGE in particular?
Yeah, it's an evolving field, and every now and then you see new guidelines popping up with more evidence. I think the general consensus is to avoid valproate in epilim, women childbearing age, and for a newly diagnosed patient. So most of us wouldn't use valproate as a first-line drug anymore. And you see the recent efforts led by Terry O'Brien has now made levetiracetam or Keppra on a PBS, and we're now allowed to prescribe according to PBS. But even before the PBS rules are changed, we've been prescribing levetiracetam or Keppra anyway. We're kind of ignoring the PBS, and many of us have been ignoring, because the defense, I think, is well defendable, is that based on best evidence, epilim or valproate should not be the first line. So the change in the PBS guidelines is welcomed, but it itself, it probably hasn't changed the practice of the specialists like myself, but maybe for the more general neurologists, they're more comfortable in prescribing levetiracetam. Yeah, so for newly diagnosed, that's what we'll start first. Again, I think the more tricky scenario is if they are controlled on epilim, what do? Do you switch them over? And in the past, I didn't, but more recently, I would. But I've also seen lots of examples where it didn't work out well. So, and ultimately you find levetiracetam doesn't work, lamotrigine doesn't work, and you still have to end up going back to valproate. But at least you made an effort, I think. And it's still, I don't think it's been satisfactorily solved, because it's just epilim or valproate is still the best drug in terms of efficacy for GGE.
It does sound like a tricky path to navigate, and sort of dependent on something you just have to travel with.
Yeah, and the dose is important. I'm sure you'll be talking to Terry at some point, but if you keep the dose down, you can manage a lot of the structural birth defects. The question is more around other behavioral consequences like autism or ADHD or learning problems, which doesn't seem to be dose related. So I think that's less certainty around these more behavioral, developmental questions.
Yeah. Interesting. And I think there might have been some work. I know Eliza Honeybun, one of the neuropsychology registrars, who's just started, is looking a little bit more at that and autism spectrum kind of outcomes. In terms of balancing or navigating sort of anti-epileptic drugs and contraception at that sort of when the patient's considering starting a family, are there any considerations or do certain AEDs reduce the efficacy of contraception or vice versa in terms of some of those interactions?
If it's in terms of drug interactions, then obviously enzyme-inducing drugs can reduce efficacy of the pills. So carbamazepine typically can reduce efficacy for the oral contraceptive pills, and generally you have to recommend the woman take a higher dose of the pills, which brings its own potential problems. So they're best avoided if you can. The enzyme-inducing drugs, if the patient needs to take enzyme-inducing, take the oral contraceptive pills. The interaction with another one well-known is more with lamotrigine. It's very complex. It's a bidirectional interaction. So the pill can increase the metabolism of lamotrigine, and lamotrigine can do the same to the pill as well. So it's a bit more complex. In reality, I find that the actual impact on seizure control is probably not as significant than what you can measure in the blood test. And that's probably because lamotrigine has a very wide therapeutic range. If you look at the blood level, it gives a very broad range, 1 to 14 or something. So very broad range in terms of seizure control. So I think it's a less of a problem in practice. But what does matter is during pregnancy, when the lamotrigine level can drop by something up to 30% or even 50%. And that's when you need to monitor the level, and we almost routinely increase the dose in the 3rd trimester for women taking lamotrigine during pregnancy.
Is that a result of pregnancy hormones and just changes in metabolism? And
it's a combination of hormonal changes and distribution sort of change during pregnancy. There's some evidence you see that change for levetiracetam as well. So since some women, I would monitor their levetiracetam level or Keppra level. Again, there's a lot of guidelines about drug monitoring during pregnancy. So in fact, there's some interest in forming some more better guidelines on what to do in therapeutic drug monitoring during pregnancy.
Thank you. I'm just keeping an eye on the time. Do we have time for? We'll maybe do one more question, and I think probably just to balance out the genders. Then there were also a couple of questions around sort of treating young men with anti-epileptic drugs and sort of fertility issues, and if there's anything on kind of possible sperm development or fertility to consider when prescribing medication for young men.
Yeah. Good question. Just to share the spotlight, but in fact, men don't matter in this regard. So there was quite an interesting. We did a study looking at hormonal changes in men prescribed different anti-seizure drugs, including valproate, and there's quite an interest about 10, 20 years ago. You can see find studies. And you find studies reporting changes in sperm count or mobility and other things, but they're pretty inconsistent. There's no clear, I think, consistency to show. Certainly no data on birth defects heterogeneity. In terms of like fertility, the evidence is mixed and is probably multifactorial. It's not just the drugs. And there are other issues that affect fertility in men and women. So I would counsel the patient and say these drugs, they don't, as a rule, they don't have a general effect on your fertility or birth defects. So for men, for instance, we would very happily use valproate if they have GGE.
Great. Well, before I might hand over to Lisa in a minute just to wrap up, but before we do, does anyone else have any sort of follow-up questions or questions about side effects that sort of following on from that discussion? No, great. Yeah, well, I'll just hand over to Lisa, but from me, thank you so much, Patrick. I think this has really been, I've been seeing a lot of nodding heads and a lot of sort of note-taking down the side, so I think this has been really a great way to do the webinar and really informative, so thank you very much.
Thanks.
Well, thank you both to Patrick and Honor. I mean, it was very interesting, and we're very fortunate, Patrick, that we can have you along and for you to share your research and insights to help us better meet the needs of our clients. This is the first of our series of seminars, and we've recorded the seminar. So for our colleagues who weren't able to make it because they're out there training or they're manning the phones, at least we'll have the recorded version for them. Just for everybody who's been able to attend today, we are planning another seminar in about 3 months' time. So keep posted. And thank you again. Perhaps we could turn on our mic, should say, and actually clap and also thank Honor.
Thanks, Patrick. Thanks, Honor.
Thank you.
Thank you.
Thanks very much.
Thanks. It's been a pleasure.
That was great. Thank you very much.
Fantastic.
Bye, everybody.
Thank you.
Bye. Thank you again, Patrick.